we'll discuss about malignant liver lesions. So let us start. So first we'll discuss about hepatocellular carcinoma. It is the most common primary malignant liver tumor. It accounts for 85 to 90% of primary liver cancers. High prevalence is seen in Asia and Africa. As we know, it occurs in cirrhotic patients 80 to 90% of time. And also HBV can cause hepatocellular carcinoma without cirrhosis. So now question arises, when do we call cirrhosis? So this question can be asked in your examination. What are the MRI findings or CT findings of liver cirrhosis? It can come in your examination. Or examiner can ask you in practical viva, practical case discussion. Okay. They will be given you some hepatocellular carcinoma, there will be background cirrhosis. So that time examiner will ask, can you tell me what are the findings which will suggest of cirrhosis? Then we should be able to tell at least some 8 points as it is there in this image. If you tell, sir, cirrhosis means irregular nodular margins. That's all. If you know only that much, then it will be difficult. You should be able to give at least 8 points. Like for example, in if they ask what is the difference between chest X-ray, PA view and AP view, you should be able to tell fatafat some 5-6 points. So if they ask what are the findings, liver cirrhosis. So can anyone, all of you, put in chat box what are the findings in cirrhosis? You can see here. I will ask question. Like for example, this first. You can put your answers in chat box. I will see. You are able to hear me, all of you?
Dr. Anil, you are audible.
In the chat box. I think some connection issue happened. So
Can share again. Yeah.
Yes. So these are the findings which we see in liver cirrhosis. First one is nodular surface of the liver, correct? Nodular, irregular nodular margins. Second one is hypertrophy of caudate lobe and atrophy of right lobe with hypertrophy of left lobe. For example, 2 and 3 segment. Then enlargement of the perihilar space, that is number 3. Then expanded gallbladder fossa. Then you can see some peribiliary cysts. Then there Sixth is intrahepatic fibrosis. Then right posterior hepatic notch. And eighth, there can be iron deposition. So these are all things we should say in exam. Okay, these are the findings. This is the image showing the hepatic fibrosis. Okay, the fibrosis is there, which is one of the criteria for liver cirrhosis. One of the first thing way to tell about is caudate to right lobe ratio. Okay, if it is 0.6 to 0.65 borderline, more than 0.65, 96% likely to be cirrhotic. More than 0.73, 99% likely to be cirrhotic. So when you are started to reporting CTs, you should try to measure this caudate to right lobe of the liver. So this is the caudate lobe and this is the right lobe. And here is the main portal vein. Here you have to draw a line and measure. So it is very simple. You should start practicing it, measuring day to day in your reporting. So in this you are seeing that liver is pitch dark in T2, but spleen is not dark. So this is a case of primary hemochromatosis. In primary hemochromatosis, there is an iron overload due to increased absorption of iron through the GI tract. So excess iron is deposited in the hepatocytes, okay, and pancreas, myocardium, skin and joints, but not in the spleen, okay. But in the secondary hemochromatosis, we can see the spleen is also dark. So secondary hemochromatosis occurs due to excessive blood transfusion or defective erythrocyte. So because of that, the iron will get deposited in the Kupffer cells, that is in the reticuloendothelial system. So here we can see in phase there is a drop in signal compared to the out phase, and then in T2 weighted we are seeing both the liver and spleen as dark. So how to quantify iron deposition? So we take something called as T2 and T2 stir. So if it is 60 to 100 per second, then it is more than, it is called iron overload. Okay. So normal liver iron concentration is less than 36. So this iron deposition quantification is a recently done studies actually. For in cardiac MRI also they do to see in patients like hemochromatosis and transfusion related cirrhosis. So this is very important point. T2 stir and T2 there will be signal drop. The other HCC risk factors are alcoholic cirrhosis, then NASH, aflatoxin, hemochromatosis, like we have seen the case before, Wilson disease, alpha-1 antitrypsin disease. So you should understand how it is progressing. First, there will be regenerative nodule, then it will become dysplastic, then it will become HCC. Regenerative nodule will have portal vein supply. Now, as we go to dysplastic nodule, HCC, there will be neoangiogenesis. So, arterial supply will happen. That is called as arterialization. That's why as we go, dysplastic nodule and HCC, regenerative nodule will not show arterial enhancement, but HCC, early HCC or dysplastic nodule will show arterial enhancement because of neogenesis. So unpaired arteries will start. So this is a very important slide. Clinical presentation is like variable, okay, jaundice, portal hypertension, hepatomegaly, hemorrhage from tumor. Ultrasound features are heterogeneous. Why it is heterogeneous? Large lesions, because it can have mosaic architecture, it will have halo side, internal vascularity will be there, and you can find portal vein tumor thrombus. The malignancy, hepatocellular, can extend into inferior vena cava or the portal vein. Heterogeneously, heterogeneous because it can contain fat, it can contain hemorrhage, like that. So mosaic architecture is one thing you should remember, which will be seen HCC. Triple phase CT or multi-phase CT we call. So it has arterial phase hyperenhancement, portal and delayed phase there will be washout with the capsule. Okay, and there will be intratumoral fat or hemorrhage. Here you can see ultrasound image. It is a hypoechoic mass. In arterial phase there is enhancement, and in the portal venous phase there is a washout. So this is the characteristic finding for hepatocellular carcinoma. Coming to MRI, T1 hypointense, T2 mild hyperintense. Diffusion restriction, intralesion fat can be there, and if there is a hemorrhage, it will be T1 hyperintense. Okay. So regenerative nodules, T2 hypointense. But you see, you will be having seen cases like prostate MRI. In that, T2 hyperintense is benign, the nodules. But in liver, it is ulta, opposite. Same in prostate, T2 hypointense is abnormal, malignancy. But here it is like this. So you should have that understanding. We should see the signal intensities. We should not be like, okay, liver, and should think of other organs also how. For example, fibroid, T2 hypointense, normal. But if something which comes T2 hyperintense in the fibroid, then we have to think whether it has gone converted into sarcoma. Yes, leiomyosarcoma. It will have T2 hyperintense, T2 heterogeneously hyperintense. So here, similarly, nodule is there. Previously, it was T2 hypointense. Now it has become T2 hyperintense. And it is showing diffusion restriction. That is malignancy. Here we can see this is a T2 image, CSF appearing bright, heterogeneously hyperintense T2. And we can see there is enhancement in the arterial phase, and there is a capsule in the delayed phase. So non-peripheral washout is the finding in MRI, means the finding of HCC. In this case, we are seeing there is a hypodense mass in the right lobe. In the arterial phase, it is enhancing. But here we can see that here the portion of IVC is there. The mass is extending into it. Here we can see there is a portal venous phase. In this we are seeing IVC, there is a thrombus. And in the delayed phase, there is a washout. So there is a vascular invasion which we see in hepatocellular carcinoma. Okay. How to differentiate between bland thrombus and tumor thrombus? Tumor thrombus will enhance. There will be arterial flow within the thrombus, and there will be streaks and threads, which we can see in tumor thrombus, streaks and threads. Whereas bland thrombus, it will not enhance, it will not show enhance. And also, for tumor thrombus, you will see that it is extending, it is coming from the tumor. That way also we can see. Now, what are the ancillary features favoring HCC? We have seen arterial phase hyperenhancement, non-peripheral washout with capsule in the delayed phase, HCC. But what are the additional findings? T2 hyperintensity, mild to moderate T2 hyperintensity. If there is a marked T2 hyperintensity, then it will go for cyst. But mild to moderate T2 hyperintensity, intralesional fat. How we can see intralesional fat? In phase, out phase. Out phase, there is a signal loss. Mosaic architecture. Nodule in nodule, appearance. Okay. Then high signal on diffusion weighted imaging, iron sparing, iron overloaded liver. Then intralesional already iron overloaded, but in the lesion there is no iron. We have to suspect HCC. These are the complications: hemoperitoneum, biliary invasion, portal hypertension, and metastasis. So lung is the most common, then followed by bone, adrenals, lymph nodes, and peritoneal seeding can happen. Now coming to fibrolamellar HCC. It occurs in young patients, 10 to 35 years, no cirrhosis, no chronic liver disease, AFP is usually normal. To
Dr. Anil, your voice is not audible.
facing some connection issues. Yeah.
Please reshare the PPT.
Yes. Now PPT is seen.
You can just close this one and just reshare it.
Yeah. Now fine. PPT is seen, sir.
Yes, you can continue.
Okay. So what are the features of fibrolamellar HCC? It will be T1 hypointense, T2 mildly hyperintense, and one most important thing which we need to know is in fibro FNH there is T2 hyperintense scar, but in fibrolamellar it is T2 hypointense scar. So there will be arterial enhancement and delayed fibrous septal enhancement, and in hepatobiliary phase there is hypointensity. And we have seen that only the FNH will show the retention in the hepatobiliary phase. So this is the finding of fibrolamellar HCC. There is a hypodense lesion with central calcifications. There is a scar, central calcification, central scar with calcification, fibrolamellar HCC. It is showing heterogeneous enhancement, but scar will not show. And in the subsequent phases,
Dr. Anirudh is joining right now.
Sorry for the
You can make it
inconvenience.
full. You can make it full screen.
Yes. So we were discussing that Fibrolamellar HCC will have this characteristic T2 hypointense scar. Okay, that is very important, and it will show enhancement in the arterial phase. So it will appear as a large solitary lobulated mass. This is very important. Why the scar will show delayed enhancement? Because it has fibrous component. So because of fibrous, it will show delayed septal enhancement. So now coming to cholangiocarcinoma. There are two types, perihilar and distal extrahepatic. So these are the risk factors. One is primary sclerosing cholangitis, liver flukes, choledochal cyst, hepatolithiasis, or chronic biliary inflammation. In mass forming cholangiocarcinoma, it will show peripheral arterial enhancement and progressive centripetal filling with capsular retraction and satellite nodules. So here you can see there is a capsular retraction. In MRI, we can see here, this is a T2. There is a heterogeneous mass, heterogeneous hyperintense mass. On contrast, it will show peripheral enhancement, and on the portal venous and subsequent phases, it will fill in. That is the characteristic of cholangiocarcinoma. So there will be capsular retraction. Now we'll see about LI-RADS. When do we can use LI-RADS? We can use LI-RADS for cirrhosis, for hepatitis B virus, or current or prior HCC. But we cannot use if it is less than 18 years, cirrhosis due to congenital hepatic fibrosis, or due to Budd-Chiari, cardiac congestion, portal vein occlusion, or diffuse nodular regenerative hyperplasia. So what are the LI-RADS major features? Non-peripheral arterial enhancement, non-peripheral washout. If there is a peripheral arterial enhancement, then what is the thing we have to think first? Peripheral arterial enhancement plus in portal venous and delayed phase, there is a centripetal filling in. That feature goes in favor of cholangiocarcinoma. Then if there is a capsule in the delayed phase and size of the lesion in the longest diameter, and we have to see for threshold growth. So one is definitely benign like cyst, 2 probably benign, 3 is intermediate, 4 is probably HCC, 5 is definitely HCC. So here is like we have seen the previous case, if the tumor goes into the vein, it is called LRT4. If it is probably malignant but not HCC, it is given LRM, like cholangiocarcinoma. Now, LR3, 4, and 5, how we have to see is whether there is arterial phase non-rim hyperenhancement, or in arterial phase there is hypo or isoenhancement. If there is arterial phase non-rim hyperenhancement, okay, and size is more than 20, that is 2 centimeters, then it is LI-RADS 4. It is LI-RADS 4. And if there is one of these things, like there is an enhancing capsule, or there is a non-peripheral washout, or there is a threshold growth, any one of them, it becomes LI-RADS 5. If both of them are there, then also it is LI-RADS 5. So size is very important. Next, if the size is less than 10, it cannot be LI-RADS 5. It has to be LI-RADS 3 or LI-RADS 4. Then coming to size less than 10 over, then if it is iso enhancement, but there is either enhancing capsule or there is a non-peripheral washout, if it is more than 20 mm, LI-RADS 4. So for LI-RADS 5, what is the most important thing? Arterial phase, non-rim hyperenhancement, plus either non-peripheral washout or threshold growth, and size criteria more than 2. So no need to, you know, just you have to see this chart, then it is fine. You can give LI-RADS score. No need to memorize. So what are the ancillary features? Like we have seen in previous slides also, if there is a diffusion restriction, T2 hyperintensity, okay, then you can upgrade it to LI-RADS 4, like that. So favor HCC are fat, mosaic architecture, favor benign are stability and marked T2 bright. So LRM category, targeted appearance, peripheral rim enhancement is there, continuous peripheral enhancement is there. But in hemangioma, discontinuous peripheral enhancement, nodular, but here peripheral rim enhancement, and it is delayed central enhancement, suggests cholangiocarcinoma or metastasis. So what is the definition of capsule? It is an enhancing peripheral rim seen in the delayed phase. For threshold, how much it should be? More than 50% increase size in 6 months, more than 6 months, or more than 100% increase size in more than 6 months. So washout definition, how you will tell? You will not tell, okay, artery may, it was hyper enhancing, HU was more. Now in portal venous space, it is less enhancing, and in venous space, it is less enhancing. Not like that. We have to compare it with the liver. With the liver, what is the thing? If it is hypo enhancement compared to the liver, then we call it as washout definition. Washout. Not with the, in arterial phase, it was very bright. Now in portal venous, it is less bright. That is not washout. So LI-RADS pitfalls are arterioportal shunts, hemangioma mimics, and abscess mimics. So now can you, any one of you tell, see this and tell what is the LI-RADS score for this? You can put in the chart. Here we can see peripheral nodular enhancement, and it is filling in, okay, and in the hepatobiliary phase, that is given gadoxetic acid, there is no uptake. Okay, and it is showing peripheral diffusion restriction. Can you tell what is the LI-RADS category? You can put in the chat. Peripheral enhancement with the filling in the delayed phase. In the delayed phase, there is a central enhancement and peripheral diffusion restriction. Yes, very good. Arisa, you are very good. You have told right. Excellent. It is LI-RADS M. Yes, LI-RADS M. Because what was the criteria for LI-RADS 5 for HCC? Non-peripheral arterial enhancement. Here it is showing peripheral arterial enhancement and washout. Here there is no washout. And also it is showing peripheral diffusion restriction. So this is a case of LI-RADS 5. Okay, now next question, please try to answer. There is a cirrhotic liver, 1.8 centimeter, arterial hyperenhancement is present, no washout, no capsule. So we have to see the chart which I have, which we have discussed. Always we have to see the chart. Unless one day you become perfect, you don't need to see the chat only. No need to see the chart. You are able to answer without seeing the chart. So let us see the answer. It is LR3, not LR5, because there is no washout. Okay. Then this one, cirrhotic liver, there is a wedge-shaped arterial hyperenhancement, becomes iso-intense later, no mass on T2. So there is a no mass. It is arterioportal shunt. Because of arterioportal shunt, sometimes you will see there is a hyperenhancement. You will say, oh, there is a mass, oh, there is a mass. But there is a no mass. Okay, 1.5 centimeter lesion, APHE. APHE means arterial phase hyperenhancement plus capsule, no washout. LI-RADS 4. Okay, no washout is there, and size also 1.5. If it was more than 2, then LI-RADS 5. 3 centimeter lesion, rim, APHE, central delayed enhancement, capsular retraction, mild biliary dilatation. LRM, yes, this is LRM. Okay, so you should remember this cholangiocarcinoma. These are the points which you remember and tell in the examination. Done. Okay, cirrhotic liver, 1.5 centimeter nodule, T2 mild hyperintense, arterial enhancement present, no washout. What is it? Only arterial hyperenhancement, cirrhotic liver. What you will give? Can we call it as HCC? LI-RADS 5? No. There is no washout, but there is arterial hyperenhancement present. So, as we were discussing, regenerative nodule will not show arterial enhancement because they are supplied by portal venous. But as it is becoming dysplastic nodule, the artery supply is becoming more, portal vein supply is decreasing. So that's why in dysplastic nodule, there will be arterial enhancement, but there is no washout. Okay, so this is a dysplastic nodule or early HCC. Okay, so this concept you should remember. From regenerative nodule to HCC, what will happen? Regenerative nodule is having more portal supply, but HCC, no portal supply, but more arterial supply. Regenerative nodule is T2 hypointense, but HCC T2 hyperintense. Dysplastic nodule will be, it will be hypointense or intermediate signal. It will show like dysplastic nodule or early HCC, it will show subtle hyper enhancement, subtle T2 increase in signal, subtle washout, or you can see there is no washout but arterial hyper enhancement. That time you have to go in favor of early HCC or dysplastic nodule. Then in HCC there is a diffusion restriction, there is a washout, there is a capsule. If there is all these things, washout, capsule, so the metastasis can occur from colorectal cancer. Other areas are stomach, breast, lung, RCC, neuroendocrine tumors, melanoma, sarcoma. How it will appear on ultrasound? It will be round, well-defined, hypoechoic lesions with hypoechoic halo. That is the target sign. So you will be doing lot of ultrasound abdomen and pelvis. If you see this target sign, hypoechoic lesion with hypoechoic halo, target sign, then multiple lesions, so many lesions will be there. It is metastasis. On CT, hypoattenuating lesions, hypoenhancing lesions with peripheral arterial rim enhancement, LRM category. Hypervascular mets in the examination or when you are attending the classes seminar, they will ask this question: what are the tumors which will produce hypervascular mets? They will produce hypervascular mets everywhere in all over the body, like RCC, thyroid carcinoma, neuroendocrine tumors, melanoma, sarcoma. Then calcified metastases are seen in mucinous adenocarcinoma, treated metastasis, or chondrosarcoma. So this is very, very important. Okay. Hypervascular mets, RCC, thyroid carcinoma, neuroendocrine tumors, melanoma, and sarcoma. So what are the MR characteristics? MR characteristics are T1 hypointense, T2 moderately hyperintense, similar to spleen, and diffusion restriction can be present. T1 hyperintense can indicate hemorrhage or melanin. So in brain also you are seeing T1 hyperintense metastasis or melanin metastasis, melanoma metastasis. Melanin is T1 hyperintense. Diffusion is most sensitive sequence for neuroendocrine tumors, and melanoma metastasis. Peripheral washout on delayed phase is relatively specific for metastasis. Peripheral washout. Hepatobiliary phase, metastasis are hypointense. Okay. Then management depends on tumor. Colorectal cancer, liver metastasis. If you remove the tumor, metastasis will go. That is the primary tumor. So these are the calcified metastases. This is target appearance, halo, and these are multiple heterogeneously enhancing lesions. So this is again the metastasis, okay, target appearance. This is neuroendocrine tumor. Here, metastasis due to neuroendocrine tumor, as we have discussed, they show diffusion restriction. So now we are going to see some rare tumors like hepatic angiosarcoma. So here we have multiple heterogeneous masses, hypervascular lesions, hemorrhage is common, and progressive enhancement. So here you can see the vessels also in this, and it is progressively enhanced. So large mass, heterogeneously enhancing, there is no washout, but it is showing progressive enhancement. We may say mimic hemangioma, but so aggressive looking, then it cannot be hemangioma. Plus, you can see so many here, so hypervascular, so many vessels. The name only tells angiosarcoma. So it is angiosarcoma. Now, this is epithelioid hemangioendothelioma. It is a low-grade malignant vascular tumor, young to middle-aged females, multifocal peripheral nodules, and slow progression. Here you see always, you remember in your PG days or for reporting any case, epidemiology is also very important. Like this thing, epithelioid hemangioendothelioma seen in young to middle-aged females. Like in pancreatic tumors, also age is also very important. This is age, this is tumor is seen. So you should remember in this way. So what are the findings of epithelioid hemangioma? It is a peripheral subcapsular nodules, capsular retraction, target sign appearance, coalescent mass in late stage, and vein is terminating at the lesion that is called lollipop sign. This thing is very rarely we see EHE and all. Okay, first you can see this here is a target sign appearance. Okay, here you are able to see target appearance in post contrast T1 lesion. So that is your EHE. So capsular retraction, what are the tumors? Mass forming cholangiocarcinoma, fibrolamellar HCC, epithelioid hemangioendothelioma, pseudocirrhosis, macronodular liver contour with capsular retraction due to treated metastasis, and confluent hepatic fibrosis, wedge-shaped fibrosis that may be seen in cirrhosis. So these are the questions they can ask. For example, if you get cholangiocarcinoma, you have told cholangiocarcinoma everything about cholangiocarcinoma, but you have not told one thing, that is capsular retraction. That is very important. Cholangiocarcinoma shows capsular retraction. Okay, you have told cholangiocarcinoma shows capsular retraction. The next question examiner will ask is what are the other tumors that can show capsular retraction? So you should remember fibrolamellar HCC, epithelioid hemangioendothelioma, treated metastasis, confluent hepatic fibrosis. So these are the questions we should be at your tip of the tongue. Now coming to primary hepatic lymphoma. It is a rare extranodal lymphoma seen in immunocompromised patient, B cell type common, minimal AFP elevation. So like we have seen in MRI brain, how will be lymphoma appearing? It will be T2 hypointense, okay? Homogeneous intense enhancement, low cerebral blood volume will be there. marked diffusion restriction will be there. That is the characteristic of lymphoma, marked diffusion restriction. Okay, but here in hepatic lymphoma, it will have minimal enhancement, but marked diffusion restriction is there. Plus, we have to think in case of immunocompromised patient, B cell type common, and multiple other lymph nodes are also you are seeing. No AFP elevation, diffusion restriction is there. N cases vessels without thrombosis. This is the characteristic of lymphoma. In other places also you have seen that sandwich sign. Lymphoma is a tumor which will engage the tumor, but there is no severe narrowing or no thrombosis. That is about the lymphoma. But the main thing here is, as compared to the brain, which shows homogeneous intense enhancement, here it will not show any enhancement, minimal enhancement. So we have to depend on MRI. That is, it shows diffusion restriction. Okay, here you can see on PET scan it is showing intense uptake. So that is how it is very important for all of us that just not see the images. We have to take the detailed history, okay, and see the patient. Also take sometimes the history from the patient. We have seen in CT you are having doubt, get MRI of that patient. Also see in ultrasound. You are seeing patient is having metastasis, but it is not known to the clinician at all. Just patient is having some jaundice, some pain abdomen. You have seen metastasis. That time you only can do chest X-ray screening, do ultrasound abdomen and pelvis, try to find the source of that thing. So we are not treating the images, we are treating the patient. So we have to always correlate with the history, clinical examination and lab. You only can see the lab values, whether AFP is elevated or not, everything. So that is our duty. Now, you can get in exam something called as combined hepatocellular or cholangiocarcinoma. Both are present. So how we know hepatocellular carcinoma will show arterial hyperenhancement, but cholangiocarcinoma will show peripheral arterial. Hepatocellular carcinoma will show washout, but cholangiocarcinoma will show filling in. Now, if both of them are there is early arterial hyperenhancement. It should have shown washout, but it is not showing washout, it is showing centripetal filling in. That time we can consider for combined hepatocellular cholangiocarcinoma. See, always we have to think rarer things rare, but ultimately in cases you have that time biopsy is the diagnosis. You can do ultrasound guided biopsy and see. So AFP plus CA 99 may be elevated. So mixed enhancement pattern. Arterial enhancement plus delayed fibrous filling. Capsular retraction can be possible. Targeted appearance can be possible. So here you can see T2 hyperintense lesion, heterogeneously hyperintense. Okay. Arterial phase hyperenhancement. Okay. But now I have to see there is a washout or not. If there is a washout, HCC. But there is no washout is there. There is no washout. So this is both combined HCC and cholangiocarcinoma. And plus here you can see there is a diffusion restriction. Okay. Plus if there is also capsular retraction, that time you can see. So this is a very again revision slide for all of you. Cholangiocarcinoma, peripheral rim enhancement, centripetal filling in. Means delayed में Not centripetal means central enhancement in the delayed phases. Whereas HCC, arterial phase hyperenhancement, portal venous and delayed phase washout, plus beautiful in this you are seeing a capsule. This is about HCC. If both are present, for example, this is present and this is present instead of this. So that time we call as cholangiocarcinoma. Understood? This arterial phase hyperenhancement is present. Instead of washout, this is present. Then it is combined HCC and ICC. So now the last few questions or examples we can say we have discussed already. Washout plus portal in delayed hypoenhancement. Capsule is there. Tumor thrombus enhances all. Okay. LRM is not equals to HCC. Central scar with calcification. Fibrolamellar HCC. And that slide you have to remember, capsular interaction is seen in cholangiocarcinoma, epithelioid hemangioendothelioma, treated metastasis, fibrolamellar HCC, all those things. Few questions let us read. What is the single most important feature for diagnosing HCC? Non-rim arterial phase hyperenhancement. Okay. Without APHE cannot be LR5. Without arterial phase hyperenhancement cannot be LR5. More than 2 centimeter size, arterial phase hyperenhancement, non-rim arterial phase hyperenhancement, LR4. Either there is a washout, either there is a capsule, LR5. Simple. Size criteria you should remember. Very important. Why does washout occur in HCC? That is why there is a washout. So washout is a phenomena relative to the liver. Yes. Why is rim enhancement not typical for HCC? Rim enhancement suggests peripheral viable tumor with central fibrosis necrosis, which is seen in cholangiocarcinoma and metastasis. And HCC, why does it show capsule enhancement? Pseudocapsule consists of compressed liver parenchyma, fibrosis, and dilated sinusoids, which enhances on the delayed phase. Regenerative nodules are dark in T2 because they are compact hepatocytes. There is no free water. That is why T2 bright. Can a lesion without washout be HCC? Yes. Early HCC may lack washout, but cannot be LR5 without washout unless more than 20 mm with capsular criteria. Threshold growth, more than 50% increase in size, less than or equal to 6 months. Biliary dilatation is not common in HCC because HCC grows expansile, not infiltrative desmoplastic like cholangiocarcinoma. Cholangiocarcinoma, another way to say it as cholangiocarcinoma is, there will be biliary duct dilatation. Most common malignant tumor in cirrhotic liver is HCC, and most common cause of false positive APHE is arterioportal shunt. Wedge shape, it will be transient, no washout. This arterioportal shunt you will see a lot actually. Okay. So thank you very much for your patience hearing, and sorry for the connection. Today the Wi-Fi connection is becoming.
It sometimes
so
happens.
just to summarize at the end, like we do in our every class, summarize. So we'll begin from the starting. So we begin our lecture with hepatocellular carcinoma. Okay. Then we saw cirrhosis is the main one of the thing where HCC can occur. We got to know what are the features of liver cirrhosis, just other than your regular irregular nodular counter of liver. We have so many things: atrophy, hypertrophy, enlargement of hilar periportal space, expanded gallbladder fossa, intrahepatic fibrosis, all those things. This is confluent fibrosis. CL, caudate to right lobe ratio more than 0.65. This is how we measure. Okay, this is the caudate lobe. Here is the main portal vein. We have to draw a line here and we have to measure. If it is more than 6.5, caudate lobe to right lobe, then cirrhosis is the one. This is primary cirrhosis, primary hemocytosis. Because spleen is not dark, only liver is dark. That is primary hemocytosis. Here both spleen and liver are looking dark. That is secondary hemocytosis due to blood transfusion, excessive blood transfusion, abnormal erythrocytes. So Kupffer cells are present. Reticuloendothelial system that is seen in bone marrow, spleen. That's why they appear dark. So in phase, there is a signal loss. Fat signal loss will be there in out of phase environment. So then we have seen the HCC features. Heterogeneous it is, okay, and there is a washout. This is a tumor thrombus case we have seen. Bland thrombus versus tumor thrombus. Tumor thrombus will enhance, bland thrombus will not enhance. Tumor thrombus will have streaks and threads in it. Plus, there we will see that it can show diffusion restriction, it will show the enhancement, and it is seen coming from the mass. That is the thing. This is very important slide. Ancillary features favoring HCC. This can come as a 10 marks question. Hepatocellular carcinoma or malignant liver lesions. Then you just write hepatocellular carcinoma means arterial hyperenhancement. There is a washout. There is a capsule. Only this much you will get this much marks. But if you write the ancillary features, mild to moderate T2 hyperintensity, intralesional fat deposition, mosaic architecture, nodule in nodule appearance. For example, there was T2 hypointense nodule. It is a regenerative nodule. But after 6 months, in that T2 hypointense nodule, there is one more T2 hyperintense nodule. That is called nodule in nodule. Now, T2 hyperintense nodule in a hypointense nodule, HCC. Diffusion restriction, iron sparing in iron overloaded liver, and intralesional hemorrhage. This is okay. Fibrolamellar HCC, what you should remember? So fibrolamellar HCC, central hypointense T2 hypointense scar. Okay, on CT you are seeing the calcification. So that's why I'm telling, like you have seen a case on ultrasound, then you do a CT, you are not able to see the calcification, you have doubt FNH or fibrolamellar HCC, you take a T2 cut, just you take MRI T2 cut, T2 hypointense cut. Oh God, this is fibrolamellar HCC. Why? Because FNH will have T2 hyperintense cut. So cholangiocarcinoma, capsular retraction, peripheral rim enhancement with delayed central enhancement. Then we have seen the LI-RADS. This is about LI-RADS. So this is very important table which you should refer. You can paste in your reporting room this LI-RADS. This is LI-RADS M, and these are some few questions which we have seen. These are metastatic lesions, hepatic angiosarcoma, targeted appearance of EHE. This capsular retraction differential diagnosis you should know, primary hepatic lymphoma, then combined HCC and CCA. So thank you so much, and thank you for your patience hearing. Yeah. So
Thank you.
because of some
Yes.
technical, I'm really sorry.
No issues. The issues happen most of the times. And thank you very much for making residents understand both the topics which are commonly asked in the table viva as long cases or short cases or somewhere in these quarters. So once the students are familiar with all the possible cases and their differentials, it is very important to go through these lessons. And you have covered beautifully in the last two sessions, and first in the benign liver lesions, now in the malignant liver lesions, and you have encompassed all the important lesions that are commonly asked in the exam. So again, thank you very much from the Radiology Without TS team, and for making some time for the residents to give what they really wanted. Thank you.
Thank you.